Assalamu alaikum, and thank you very much for this kind invitation. And I've been asked to talk about and provide an update on bladder cancer. And a lot of things have changed in bladder cancer. So it's important that we keep ourselves abreast of the latest development. One of the major thing which has changed in this year is the risk stratification and some of the new changes in the guideline, and I'm going to go a little and provide you a little overview. We know that non-muscle invasive bladder cancer is an extremely heterogeneous disease with the recurrence potential which varies from 30 to 80% at 5 years, and a progression potential which varies from 1 to 45%. So you need to identify bad from good non-muscle invasive bladder cancers, because the treatment would vary significantly. In order to do that, over the years we had various prognostic tools in the form of EORTC risk calculators, originally defined in 2006, subsequently the Kyoto model, which was 2009, and then the EORTC 2016, and very recently the EAU prognostic indicator 2021. And I'm going to just quickly describe to you some of the salient features of these nomograms. So the EAU 2021 is the latest risk evaluator or prognostic indicator for non-muscle invasive bladder cancer. It is only model that uses both the WHO 2004 and 2016 classification system. We know that low grade versus high grade and T1, T2, and G1, G2, and G3 are the two difference in models. Patients who were treated with BCG have been excluded so that the impact on progression can be assessed for the natural course of the disease. One addition which has taken place in this latest risk calculator is the addition of a risk group which is very high risk. So initially we had low risk, intermediate risk, and high risk, and now there is an addition of a very high risk non-muscle invasive bladder cancer. Something that we didn't have previously was the variant histology, which includes the micropapillary, the sarcomatoid, the plasmacytoid, the presence of lymphovascular invasion, and CIS in the prostatic urethra. They've all been categorized into very high risk group. Primary CIS again is a high risk, and recurrent tumors have been assessed as well. So if we look at the changes, we can see that there is a significant difference in 1 year probability of progression between high and very high risk. So the first 1 year progression potential for high risk is 3.5%, whereas in very high risk it is 16%. So it's significantly higher in very high risk group compared to the high risk group. So it's important that we differentiate. Again, at 5 years, it is 10 versus 40%. So again, a 4 times difference in progression potential at 5 years. So based upon this new category of very high risk bladder cancer has been identified, has been classified, and now it should be used to distinguish high from very high risk, because the treatment varies significantly. Now, if you look at the 2024 EAU guidelines, only recently released in the Paris meeting, we are seeing that significant changes have been made in those guidelines. A new category of high-grade recurrence during or after BCG therapy. BCG has become the de facto treatment option for aggressive non-muscle invasive bladder cancers. Anything more than intermediate risk are treated by BCG, so very high risk cancers. BCG exposed patients now impose another new group of patients that we need to look into. So the table 7.2 describe BCG exposed tumor category, and there's some other changes as well, which includes how to deal with low-grade recurrence in BCG treated patients, and the intermediate risk bladder cancer group and how to treat them. The follow-up strategies have also been now looked into and have been made a little more less stringent. So I present to you a case, 67-year-old smoker, gross painless hematuria for the last 3 months, variable intensity, and it's been off and on. Ultrasound examination showed a posterior wall bladder growth. He was advised TUR. A TUR was done, and as you can see, there is small papillary growth. It's relatively broad-based, but smallish growth, less than 3 centimeters on the posterior wall of the bladder, which was resected, and the histopathology showed a high-grade disease. Now, if we place this patient on our risk calculator, and this is the risk calculator that you can all download on your mobile phones. Both Android and iPhone applications are available. So this patient is less than 70 years. So this is the primary tumor. There was the main tumor that I've shown you, and there was a small tumor as well. So multiple tumor, 3 centimeters. T1 concomitant CIS was not present, and it was high grade. So based upon these parameters, this patient has a probability of progression after TURBT without induction or maintenance BCG, and is categorized as a high-risk bladder cancer with 1 year progression of 3.5%, 5 year about 10%, and 10 years about 14%. So based upon these factors, you would recommend treatment in your patient. So patients, if you look at the guidelines, very clearly that we should stratify patients into low, intermediate, high, and very high risk category. And you can determine that by using the nmibc.net. This is something that you can download through this website, and it is strongly recommended by the guidelines. Now, the 2006 EORT scoring model to predict the risk of tumor recurrence in individual patient is treated with BCG is also strongly recommended. So the 4 risk categories, as I've been mentioning, these is low-grade tumor, low-risk tumor, which is a primary single TA low-grade tumor, which is less than 3 centimeters without CIS in a patient who is less than 70 years of age. So these parameters are fulfilled, and if any of these parameters is not fulfilled, this becomes intermediate or high risk. Now, a primary low-grade tumor with at most one of the following additional clinical risk features become high risk, and intermediate risk is somewhere in between the low and the intermediate risk, low and high risk. Whereas a very high risk patient is TA high grade with CIS and all 3 risk factors. The risk factors are age greater than 70, multiple tumors, tumor diameter of greater than 3 centimeters, and stage T1. The T1 G2 tumor with CIS, at least 2 risk factors, T1 high grade, and so on. So essentially, tumors with CIS in the prostatic urethra, tumor with lymphovascular invasion on your histopathology, and any of the variant histopathology like micropapillary, plasmacytoid, sarcomatoid, differentiation, etc. So all these features present, your patient becomes a very high risk category, and they should be treated as such. Another case of a 68-year-old lady, non-smoker, gross hematuria, recurrent episodes over the past 2 months. The ultrasound showed again a posterior wall growth, looks rather solidish. Cytology ×3 was unremarkable, and she underwent MRI scan as well, which again is shown here, which shows nice papillary configuration of the growth, and you can very clearly see in the layers of the bladder. In MRI scan is becoming, the new standard in the evaluation and management of bladder cancer patients, because often you can actually do the VIRAT scanning, the VIRAT categorization, and will be able to differentiate T1 from T2 and T2 from T3 tumors. So again, cystoscopy is obviously done, and the cystoscopy showed this tumor. So she has single greater than 3 centimeters tumor, which is TA without CIS, and it's low grade on histopathology. This all indicates a low risk cancer, and she was categorized as a low potential of progression at 1 in 5 years. So again, these are some of the patients who can be managed by resection followed by a single dose of intravesical mitomycin C, and followed by follow-up, which is 3 months, 9 months, and then yearly for 5 years. So again, summarizing, low-risk patients are the ones who have got a primary single TA low-grade cancer, which is less than 3 centimeter without CIS, in a less than and younger than 70 years of age patient. So intravesical therapy is really recommended in low-risk patients in whom there is a recurrence detected more than 1 year after previous TURB. Generally, low-risk patients can be treated by a single intravesical installation after surgery and nothing else, as long as they remain disease-free. Single installation definitely significantly reduces the. Now, we are seeing a lot of geriatric patients, and again, this is a 79-year-old male, history of diabetes, history of ischemic heart disease and status post coronary artery bypass grafting, valvular heart disease on warfarin. So a lot of medical issues. He had recurrent gross hematuria, which was initially ascribed to use of warfarin. However, his in one of the episodes during hematuria, he was admitted in the hospital and developed an MI. So this was about just over 2 months back. Obviously, he's considered as a very poor risk for anesthesia, and this patient was advised flexible cystoscopy to actually see if there is any chance, any bladder growth. So cystoscopy indicated a small papillary growth in the bladder. Now, how to treat these patients who cannot even have a proper TURBT? Now, this is interesting data on chemoablation, that patients who've got low or intermediate risk cancers in whom surgery is difficult or not possible because of the significant risks, these patients can be chemoablated, and the cure rate of is seen in 1 in 3 patients, so about 37%, and which is biopsy proven. So biopsy shows no recurrence of disease. Only visible cystoscopy shows about 60% complete cure rate. So if there is good compliance, there are less side effects, and these patients can be treated by chemoablation alone. And this is the risk, this is the summary of patients who are intermediate risk, like this gentleman. The chemoablation with mitomycin or epiribicin can be done 6 cycles as is usual, and maintenance can be given in higher risk patients up to 1 year. Now, what about high and very high risk category patients? The major concern in this group is that of progression from T1 to T2 disease, and in this way they become eligible for more aggressive treatment. So we know that now we can separate high from very high risk patients, so that these very high risk patients are probably candidate for more aggressive treatment right from the beginning, rather than conservative treatment with intravesical BCG. So high and very high risk patient, explain the risk and consider radical cystectomy for very high risk patient, even in the initial stages. For high risk patient, intravesical BCG of 1 to 3 years is recommended. Cystoscopy and cytology at 3 months is also highly recommended. If negative cystoscopy and cytology every 3 months for 2 years, then we move on to every 6 months evaluation until 5 years, and then yearly for evaluation with CT or intravenous urogram to evaluate and look for upper tract involvement. So patients who've got positive cytology with no visible tumor in the follow-up, they should have an upper tract evaluation, which is strongly recommended. Bladder random biopsies be taken, and prostatic urethral biopsies be taken, and if possible, and if you have the facility, you should do PDT to rule out unrecognized carcinoma in situ. So if the biopsy showed non-muscle invasive recurrence, consider previous histological report and then treat these patients accordingly. If there is muscle invasion, then obviously look into the muscle invasive bladder guidelines, which essentially tells you that you need to do your radical cystectomy as an option with or without your chemotherapy. Now, carcinoma in situ we know is a difficult condition to manage. And without any treatment, nearly half of the patients would progress to muscle invasive disease. The risk factors for carcinoma in situ is concomitant T1 tumors, extended carcinoma in situ involving most parts of the bladder, or carcinoma in situ in the prostatic urethra. So these are the high risk CIS group patient. Approximately 10 to 20% have a complete cure from intravesical BCG. About 60% are non-responders, and for these non-responders you need to be aggressive in treatment with cystectomy. So in carcinoma in situ there is severe cytological atypia, which consists of loss of polarity, as you can see in the histopathology, nuclear enlargement, and hyperchromasia. So it's important your pathologist is conversant in diagnosing carcinoma in situ, because it is not an easy condition to diagnose. So this is again new in the guidelines coming this year, and it is proposed that we need to be a little more stringent, little less stringent in the follow-up using imaging in low and intermediate risk patients. So imaging is not really required, and follow-up for low risk is total for 5 years, for intermediate risk a total for 10 years, And for intermediate risk, it's important that you do 3 monthly cystoscopies. And then after 2 years, if there's cystoscopies for the first 2 years is negative, then go on and do the 6 monthly for up to 5 years, and then annually. For high and very high risk patients, cytology is mandatory. It is important that you do it for 3 months, for 2 years, and then 6 months up to 5 years, and then annually. CT is done annually to up to 5 years, and then CT every 2 years for up to 10 years. The follow-up is lifelong in high and very high risk patient. So what has changed is that intermediate risk patient, the no systematic evaluation is required. Now, what about radical cystectomy? A few words about radical cystectomy for non-muscle invasive bladder cancer. It improves the staging accuracy, because it is seen that 1/4 to half of the patients are upstaged to muscle invasive bladder cancer. So they actually have muscle invasive, which we have not been able to diagnose. NMIBC experienced disease progression to muscle invasive, have a worse prognosis than in de novo muscle invasive cancer. The risk factors include morbidity and impact on quality of life, very high risk disease progression, BCG responsive tumors, which are all have a very poor prognosis. A delay in radical cystectomy may lead to decreased disease-specific survival. In patients whom radical cystectomy is performed before progression to MIBC, the 5-year disease-free status rate exceeds about 80%. A word about imaging. Imaging has really changed in bladder cancer now, and we are all used to the PIRAT, and now there is a lot of talk about the VIRADS, which is the vesical imaging, using an multiparametric MRI scan, very similar to the one that we have been using in prostate cancer, but now for bladder cancer as well. There is good quality data available, but again, the availability and the radiologist ability to read these VIRAD scan is still not uniformly available everywhere. So this is something for the future, and we need to really be cognizant of these developments. So if you look at the guidelines, this is reflected in the guidelines that the local staging with MR scan is recommended as an option coming from these, and these are the older guidelines which were predominantly CT based. Thank you very much for your attention, and I hope you have learned something new today about the latest developments in bladder cancer. It's a highly heterogeneous disease, and we need to be aware of what are the new recommendations so that we can treat our patients well. Thank you very much for your attention.